Welcome to this briefing video for SAR Alan. My name is David Pride and I chair the review panel. Many organisations have adopted the practice of keeping verbal briefings limited to 7 minutes because research shows this is the optimum time span for a person watching a video to concentrate and learn. If you want more detail about this review, the full SAR report is available on the Kent and Medway Safeguarding Addicts Board's website. Alan was 79 years old and a long-standing diabetic and stroke victim when he sadly passed away in hospital in March 2021. He had been admitted with multiple grade 4 pressure ulcers and concerns had been raised about his living conditions at home. Alan had received voluntary care from his son and only living relative Barry. No other statutory agency, charity or person was involved in supporting either Barry or Alan. In April 2018, Alan was admitted to hospital with sepsis. After treatment and residential rehab, Alan went home. All offers of care support and home visits by a physiotherapist were turned down. There was no reason at that time to believe Barry was not willing or not able to provide the appropriate level of care for Alan. In February 2020, Alan was taken to hospital by ambulance and later discharged the same day with antibiotics. Although it was discussed Barry was struggling to cope with the 24/7 care Alan required, no safeguarding concern was raised with adult social care. Please consider, as a rule of thumb, if you raise verbally a safeguarding issue with another professional, that is the time to follow your own internal procedures and formally record your concerns. There were some gaps in the communication between the hospital and the GP in 2020. These are being addressed by the Kent and Medway ICB in partnership with acute hospitals and mental health providers. They want to identify what information any electronic discharge notice to a GP should contain. There is no need to dwell on these issues as this is work in progress. It was unusual, but not unique. The only contact Alan had beyond Barry was with his GP and at his diabetic outpatient appointments. Both these services were severely disrupted by the restrictions imposed by COVID, and all contact with Alan during lockdown was by telephone. It is widely recognised people caring for family and friends at home provide a valuable, if not essential, service. But it does potentially come at a personal cost to the person providing the care and ultimately the person being cared for. Everyone has the legal right to decline care or support, and this is a choice they are entitled to make, even if this would be viewed as an unwise choice by others. Currently, once a care needs assessment has been offered and declined, there is no further active involvement by statutory agencies, unless Section 11 of the 2014 Care Act applies. In Kent, there are 150,000 volunteer carers, and this number will increase exponentially as the population grows older. It is probably no longer enough to record a social care or health service care needs assessment and or carers assessment has been offered and declined, without identifying what the possible future risks might be if circumstances change. A professional judgment needs to be made to assess how effective this care is likely to be over time. The following prompts also apply to other professionals when they encounter a person who has been looked after by a sole carer, because circumstances change over time, and what was in place when support was offered may no longer be there. Please ask yourself the following questions. What level of caring support is being provided? Is this a 24/7 role and being carried out by a sole family member without any obvious additional help or support? How sustainable is that? Is the carer also frail or under medical care? Are they vulnerable through alcohol or recreational drug use or financial hardship? Or do they have other caring responsibilities? What information about the family is known by other agencies? Is this relevant? Why is the offer of support being declined? Are the reasons given reasonable and fair to the person being looked after? Are there any cultural or ethnic barriers to consider, and how do you overcome these in a sensitive and in a compassionate way? Are there support structures or networks that may provide an early indication that the carer may not be coping? This could include faith organisations or charities such as Age Concern. Is the person being cared for engaged with other services such as their doctor? Do they have annual medication reviews, learning disability annual checks, or do they have the 74 plus annual GP health check? Should the GP be alerted that the current caring arrangements should be monitored by them as part of these other processes? Will signposting the family to support services, both statutory and third sector, be beneficial? Does the person being cared for have the capacity or capability to follow up with these recommended organisations? Is the carer likely to follow up on this advice? If not, why not? And does this present the risk of future harm? Addressing these questions will allow you to make a professional judgment as to whether any follow-up action may be required either now or in the future. I would like to conclude this 7-minute briefing with some good practice. When Alan was conveyed to hospital for the last time, the attending paramedics and district nurses both used the self-neglect and holding clutter score to identify the condition of the home. They believed this presented a significant risk of harm to Alan because of his limited mobility and failing eyesight in the event of a fire. Please build on this good practice and always reference the clutter score when documenting the condition of a person's house. Thank you for listening.